Good afternoon. Can y'all hear me? Perfect. Let's see. So to VBAC or not to VBAC? This presentation was originally done with St. Thomas Health as part of an emergency simulation program in which I presented for, can you hear me? Okay. I presented for about 30 minutes and then we would do a module on postpartum hemorrhage resulting from VBAC. So Dr. Van Hodonk is a Vanderbilt faculty member that also created it with me. So to start, I'm going to begin with objectives. The first objective is to examine the risk factors of attempting vaginal delivery after C-section. And the second objective is to be able to counsel the patient on her risks. I think it's also important to clarify terminology. TOLAC is a newer term, and that's the trial of labor after C-section, whereas opposed to VBAC is the vaginal birth after C-section, or the successful completion. I think a lot of times in the lay population, your patient will come and talk to you and say, I want to talk to you about VBAC. But it's really important to set their expectations of what they really want to talk to you about is TOLAC. They want to try for it. Every effort of a TOLAC does not mean necessarily a VBAC. And then there's also, you'll see written throughout the presentation, ERCD, which is elective repeat cesarean delivery. So anytime you talk about a really controversial subject, I think it's important to kind of look at the history of VBACs. Between 1970 and 2007, the C-section rate in the United States rose from 5% to 31%. Before 1980, the general rule was one prior C-section was a repeat C-section in the future. I even heard when I was in residency here at Erlanger, once a C-section, always a C-section. In the early 90s, TOLAC was recommended. However, in the late 90s, there started being case reports of bad outcomes, fetal deaths due to uterine rupture. Also in 1999, ACOG came out with a guideline stating that the obstetrician had to be, quote, immediately available. This was definitely a game changer for a lot of obstetricians. So in early 2000, after all the case reports and ACOG stance, the VBAC rate decreased. However, in 2010, the ACOG practice bulletin encouraged VBAC, which was later reaffirmed in 2013. And their statement was that most women with one previous cesarean delivery with a low transverse incision is a candidate and should be counseled about VBAC and offered trial of labor after C-section. So this kind of shows the progression of C-section rates, and you see here, and I'm sorry, VBAC rates, and you see in 1999 where they started having a decline in VBAC rates. This is a little bit different representation of it. You see how VBAC, of course, peaked here in the mid-90s and then has just steadily declined to abysmal. You have the primary C-section rate as a whole going up. I'm sorry, primary C-section rate going up, and then the total cesarean section rate going much higher than ever before. So when we talk about TOLACs, we have to consider what the maternal risks are. Of course, you have the failed TOLAC rate being about 30%. Most maternal morbidity that occurs during TOLAC occurs when the repeat C-section becomes necessary. In other words, a failed TOLAC is associated with more complications than an elective repeat C-section. And the risk for maternal morbidity is related to the woman's probability of successfully achieving this VBAC. The risk for maternal hemorrhage with transfusion is about 1 to 3%. And that, according to the NICHD and the collaborative with MFMU, shows the risk of hemorrhage with blood transfusion is about 1 to 1.4% with an elective repeat C-section. It goes up to about 0.7 to 1.7 with TOLAC with one prior C-section, and it goes up to a 3.2% risk of blood transfusion after 2 or more C-sections. Other risks, this is, I think, even as a medical student, I knew about risk with trial of labor after C-section, the risk of uterine rupture. You're looking at about 1% with one prior low transverse, 2% if a prior low vertical, and anywhere from 1 to 12% if a prior classical, and a 6% risk if you have a prior inadvertent extension during your primary C-section. There's also, which we'll touch on later, neonatal death and neurologic injury, and about 10% of ruptures, you have a bad baby, or 1 in 1,000 trials of labor after C-section. You also have maternal infection and even maternal death with TOLACs. So this is taken from Cunningham and Williams Obstetrics. 1 in 100 trials of labor will result in uterine rupture. 1 in 10 of those ruptures, there will be neonatal death or neurologic injury. So in other words, in 1 in 1,000 trial of labors after C-section, there will be neonatal death or significant injury. And I think this is a really important statistic to take with you when you counsel your patients. So this is taken from Practice Bulletin number 115, and this kind of shows, like I was speaking to earlier, the risk of blood transfusion, hysterectomy, death. So this is actually taken from an up-to-date article, so the math is a little bit different than the 1 in 1,000, but in this article they said in a hypothetical group of 100,000 women at term who undergo TOLAC rather than elective repeat C-section, there will be 9 fewer maternal deaths, 650 additional uterine ruptures, and 50 additional neonatal deaths. So let's talk about some good things about VBAC, because who's wanting to do VBAC after hearing all those risks? So some of the benefits of a successful VBAC are decrease in bleeding, lower infection rate, shorter hospitalization and recovery period. You're less likely to have maternal operative injuries associated with higher number of C-sections. And you're also decreasing the risk of abnormal placentation if you have a lower number of C-sections. And also, if your likelihood of success is greater than 47% with a trial of labor after C-section, it is more cost-effective than an elective repeat cesarean delivery. And you're probably thinking, well, where'd you come up with that bogus 47%? And how can we come up with a number when we're trying to predict someone's success? And we'll get to that. So, risk to baby. There's an increased risk for required neonatal resuscitation, increased risk for intubation for meconium-stained amniotic fluid, increased risk of neonatal sepsis, hypoxic ischemic encephalopathy. In fact, according to the NICHD and an MFMU collaborative, the risk of HIE with TOLAC is 46 per 100,000 compared to 0 with elective repeat C-section. Also, there's a risk of neonatal death. But interestingly, there's no significant difference in the 5-minute APGAR or NICU admissions. I don't know how we all can see this in the back, but this is a really good graph that kind of shows, it stratifies the risk from common to very rare, with common being up here to very rare of both VBAC and also the repeat C-section. And you, of course, have your risk of hysterectomy being a little bit more prominent with the repeat C-section compared to a VBAC attempt. And also you have maternal death is, of course, less common with a successful VBAC. So who is the candidate? Who are we going to offer this to? ACOG says that the overall probability of a successful VBAC is 60 to 80% if one prior low transverse uterine incision. So the incision types are low transverse, and even ACOG says low vertical. You can offer them a TOLAC. Also, this was different from when I was in residency, but an unknown uterine scar, you can offer them a TOLAC as long as it's one prior C-section, unless, and they're very specific about this, there is a high clinical suspicion of a previous classical. For instance, if they delivered, say, 25, 26 weeks, or if they delivered in a country that might be notorious for classical C-sections. I remember as a resident always going on these crazy goose chases trying to find operative reports from all these different foreign countries to see what the incision was on the uterus. But ACOG actually says, as long as you have reasonable belief that it wasn't a classical, you can offer them a TOLAC. Also, if they've had 2 or less prior low transverse C-sections, you can offer them a TOLAC. If they have twins this pregnancy with 1 prior low transverse, you can offer them a TOLAC as well. And of course, they need to have a vertex presentation in the current pregnancy. However, you can attempt external cephalic versions on people with uterine scars. So an ECV is not contraindicated with a prior C-section. And ACOG really likes to emphasize that it needs to be a motivated patient. And ACOG defines a good candidate as, quote, a woman in whom the balance of risks is as low as possible and her chance of successes are as high as possible. And that this balance between risk and chance of success is acceptable both to the patient and to her doctor. So what makes you more likely to have a successful trial of labor after C-section? So these people are the best candidates. If their prior C-section was for a non-recurring condition, like breech, non-recurring fetal heart tones, if she's had a prior vaginal delivery, if she presents in spontaneous labor, and if she has an appropriate size fetus. Things that decrease her probability for success would be like a recurrent indication. So if she had a labor dystocia, like an arrested descent, an arrested dilation, you might be concerned about the size of her pelvis. And things that aren't quite as predictive in decreasing the probability would be advanced maternal age, non-white ethnicity, specifically people of African descent, a gestational age more than 40 weeks, maternal obesity, preeclampsia, short interpregnancy interval, and an estimated fetal weight more than 4,000 grams. And not just increasing the risk for a failed TOLAC, but also increasing the risk for uterine rupture is if there's no prior vaginal delivery and a large for gestational age infant. And other things that increase your risk for uterine rupture, thereby a failed trial of labor after C-section, is a labor dystocia at advanced dilation of more than 7 centimeters. So, on the flip side, the lower probability for successful VBAC would be a prior C-section for failure to progress, no previous vaginal delivery, and induction. So this is a VBAC calculator that was done by the MFMU, which was a collaboration of different academic centers all over the country, a few centers in California, I believe Emory. Dr. Brown had said that Duke used to be a part of MFMU, and he corrected me and said they no longer are. But they kind of came up with a database and trying to help people predict what the possibility is of having a successful vaginal birth. This table is for antenatal counseling. Some caveats of this are it assumes one prior low transverse C-section, a singleton pregnancy, and a cephalic presentation. They also have one for on admission, so you can kind of go through both antepartum and on admission and be able to calculate this. They have apps on your phone for this, so you can put this on your smartphone. Now, once again, ACOG says that women with at least a 60 to 70% chance of VBAC have an equal or lesser maternal morbidity when they undergo TOLAC than women undergoing elective repeat C-section. But it's also important to emphasize there's no reliable way to predict which trial of labors after C-sections will fail. So who do we not offer it to? First, definitely need to emphasize if they've had a prior uterine rupture or dehiscence, you don't need to be offering them a trial of labor after C-section. The risk for occurrence is at least 6%, and that's if the previous uterine rupture was confined to the lower uterine segment. That's a pretty high recurrence risk. If the uterine rupture was involving the upper uterine segment, that's a recurrence rate of almost 32%. So definitely somewhere where the operative can help you, but really if they report a history of uterine rupture, you probably should not be offering them a TOLAC. Also, if they have a prior classical incision, like I mentioned, a 12% recurrence risk, a prior T incision on the uterus, about a 6% recurrence risk, and also in someone, say, who is their first pregnancy, a primogravid, if they've had prior extensive transfundal uterine surgery with myomectomies and dissection into the myometrium, you probably don't need to be offering them labor in general. And other contraindications to vaginal delivery, if they have malpresentation, abnormal placentation, like a placenta previa, you don't really need to be offering them a trial of labor after C-section either. And also, not 2 prior C-sections, but if they have 3 or more C-sections, you don't need to be offering them a TOLAC either. And when we talk about uterine rupture, I think it's important to remember uterine rupture can occur spontaneously. It can happen in an unscarred uterus, or it can happen with a known or unknown history of uterine perforation, say if they had had a D&C before. So you always have to consider a uterine rupture. So induction of labor with prior C-section. This is a very controversial topic right now. It is acceptable by ACOG standards. There are mixed opinions on whether induction carries a higher risk of failed trial of labor after C-section compared to expectant management. But what we do generally consider to be true is that induction and augmentation carry increased risk of uterine rupture. The rate of rupture with Pitocin is upwards towards 1.4%, and that risk is even higher if there's no prior vaginal delivery. And it increases even more if you start the induction with an unfavorable cervix. They do think there may be a dose-response relationship. Some experts suggest that Pitocin limitation should be considered, citing a dose-response effect with increasing risk of uterine rupture with higher maximum doses of oxytocin. A study by Cahill suggested limiting your Pitocin to about 20 milliunits per minute and not doing the higher dose Pitocin. But other experts suggest an increase of uterine rupture is associated more so with tachysystole and not so much the actual concentration of Pitocin. The important thing to remember, though, is no prostaglandins, no side effect with these people. But a Foley bulb is acceptable, and it's also recommended for mechanical dilation to help improve their chances. And an IUPC is safe with people with a prior uterine scar. But there is no consensus on the maximum dose of Pitocin. But once again, the best scenario is a favorable cervix with prior vaginal delivery for induction. Now, July 2015, Lappin came out with an article in the Green Journal that kind of turned a lot of what people consider to be true about induction and TOLACs around. This study was interesting because it compared induction to expectant management. Most of the prior studies were induction to spontaneous labor, but Lappin's article looked at induction to expectant management from 37 to 40 weeks. And it concluded that from 37 to 39 weeks, induction was associated with an increased risk of failed TOLAC, but at 40 weeks, there was no difference in the rate of successful VBACs. They did see an increased risk of blood transfusions, which I spoke to earlier, and their study actually showed that induction was not associated with an increase in uterine rupture. They did, however, they did also say that induction was not associated with an overall increased risk of neonatal morbidity, nor actually in maternal morbidity, just in blood transfusion. So signs of uterine rupture. The fetus usually shows the first signs. This really highlights the importance of continuous electronic fetal monitoring in patients with a trial of labor after C-section. Variable decelerations are the most common fetal heart rate tracing associated with rupture, followed by fetal bradycardia, but there is no fetal heart rate pattern that is pathognomonic for uterine rupture. And you always need to be acutely aware of sudden changes in the fetal heart rate tracing. If it's a category 2 tracing in someone with a history of prior C-section, you probably need to consider a C-section, because once again, no tracing is pathognomonic and the goal is timely intervention. You also once again need to consider uterine rupture even if there's no prior C-section and you see acute rapid decelerations. And if the fetal heart rate changes, you should probably consider or assume it's uterine rupture until proven otherwise. And you need to be careful to not, especially in people with a prior uterine scar, not assume that the decelerations are caused by rapid cervical change or head descent. Like a lot of times we're like, they're just changing quickly. With someone who's attempting a VBAC, you probably don't want to assume that it's just rapid cervical change and assume it's uterine rupture until proven otherwise. So signs in the patient. There's the classic, even as medical students we learn this, vaginal bleeding, maternal hypotension, sudden or worsening abdominal pain. This is something where I think historically they would say, these women can't have epidurals. How are we going to know if she's having uterine rupture? Remember, you look at the fetus, you look at the heart rate tracings, and an epidural is acceptable and it will not mask the signs of uterine rupture. Some people also cite the staircase sign where you have the gradual decrease in the amplitude of consecutive contractions, but sometimes there can be no change in contraction pattern with uterine rupture. There's also shoulder pain, which of course is the referred pain when you have blood under the diaphragm to the shoulder. You have a loss of station or a fetal presenting part. And you also need to be mindful of the labor dystocia after 7 centimeters dilation, because labor dystocia is a risk factor for uterine rupture as a result of prolonged exposure of the hysterotomy scar to prolonged uterine contractions. And something to consider, even if you do have a successful VBAC, you need to be wary of maternal complications in the immediate postpartum period from an unrecognized uterine rupture, like abdominal pain or an unexplained anemia, because you may have more blood loss than you can actually visualize, especially if you did an operative vaginal delivery in the second stage for non-reassuring fetal heart tones. So, what is required to offer a trial of labor after C-section? First, you need to consider your resources. You need to have patient consent. You need to have the availability of a continuous fetal heart rate monitoring. You need to have adequately trained nursing staff. The obstetrician should be immediately available, and that's per ACOG or really in-house. Gone are the days where you could be down the street and just having them watch it. You need to be immediately available. You also need a 24-hour anesthesia presence, an OR staff surgical team that's available, adequate blood supply, and a higher level of NICU. If you're going to undertake this, you need to be letting everyone know as soon as the patient comes. You need to let anesthesia know, hey, I have someone who's attempting a trial of labor after C-section. So that if they get a call, they know they need to run, put down the crossword puzzle and go. And also make sure the neonatologist knows what you're attempting. Because if emergent fetal rescue is indicated, every minute counts. This is not something we should be trying at home, because fetal decompensation with uterine rupture is precipitous and rapid. This is a homegrown study, but basically talks about the time to delivery from suspected uterine rupture from the suspected uterine rupture to the actual delivery and the neonatal outcomes. Really, you need to be able to perform C-section in less than 15 to 20 minutes, ideally 10 to 15 minutes. And that's not from the diagnosis of uterine rupture, that's from the appearance of the abnormal fetal heart rate tracing. This study was in the Green Journal in April 2012, and their conclusion was that no neonate delivered in less than 18 minutes from onset of the abnormal fetal heart rate pattern, had a cord pH of less than 7.0. That's 18 minutes. I would still try for 10 to 15. They also had a conclusion that decision to delivery time of more than 30 minutes was associated with poor long-term neonatal outcome of fetal neonatal death and long-term neurologic sequelae. So I work in the Ascension system, specifically at St. Thomas Hospital up in the Nashville area. And so we have this policy that basically outlines for all the different physicians what's necessary for attempting a trial of labor after C-section. And there is, if you happen to have a printout of this, we have since made a revision to it to where it was unknown scar is not a contraindication to VBAC. That's of course only with one prior C-section. If you have an unknown scar with 2 prior C-sections, you cannot offer them a trial of labor after C-section. And ACOG has tremendous resources to be able to talk to patients and really document your conversations with patients about the discussion of trial of labor after C-section. This one's for the antepartum period, and it's a great reference. And there's also one for when they come in for admission, be it spontaneously laboring or if they come in for induction. And it goes to what I spoke to earlier, your documentation of notifying all the other parts of the team, all the other people who are going to be involved if things don't go well. So some of the ethical considerations with VBAC. First, you have to consider beneficence. The welfare of the patient is central to all the considerations in the patient-physician relationship. We must respect her autonomy and the right for her to make her own choice. And as physicians, we should not misrepresent ourselves through any form of communication in an untruthful, misleading, or deceptive manner. This gets to informed consent. Most of us, when we think of informed consent, we think document, document, document. But informed consent really is more so a process. It's not a signature, and it's an expression of respect for that patient. ACOG's stance with informed consent and TOLAC is after counseling, the ultimate decision to undergo a trial of labor after C-section or an elective repeat C-section should be made by the patient in consultation with her doctor. And informed consent, of course, contains 2 parts. Comprehension. This is making sure the patient understands what you've told her, because only if she comprehends what you've told her is she really giving the freedom of consent. So in conclusion, ACOG recommends offering trial of labor with 1 previous C-section with a low transverse incision. The best combination for successful VBAC is if they have spontaneous labor, a history of prior vaginal delivery, and if their prior C-section was for a non-recurring condition. And this is what I tell my patients. Bottom line, if we do an elective repeat C-section, that's what's going to be safest for your baby. But if we're successful, a VBAC is what's going to be safest for you. But ultimately, your patient makes the decision. Thank you.